Thank you so much for joining us for today's webinar. My name is Jessica Holsey with Addiction Policy Forum. APF is very excited and proud to be a part of the National Center for Health and Justice Integration for Suicide Prevention, also known as NCHATS, and really excited to introduce our researchers and webinar speakers to you today to really talk about the background, the need for the center, and the work that that's currently underway. I also want to first quick introductions. Our presenters today, first we have Dr. Jennifer Johnson, who's a professor of public health at Michigan State University. She's a licensed clinical psychologist and specializes in mental health and substance use interventions for vulnerable populations. We also have Dr. Lauren Weinstock, who's a professor of psychiatry and human behavior at Brown. She specializes in behavioral interventions for mood disorders, as well as suicide prevention. The work that NCHATS is doing is so critically important as we address vulnerable populations that are at risk for suicide. And so we're so excited to have so many practitioners, key stakeholders, policymakers, and other researchers join us for today's event. And I'm going to go ahead and hand this over to Dr. Johnson. But again, thank you so much. I'd also like to thank our team, Braden Kelly and Grace McGann, for helping to coordinate today's webinar and all their work that they do to support the dissemination and stakeholder engagement with NCHATS. It's very exciting to be a part of this center. So Dr. Johnson, can I hand it over to you?
Thank you. Thanks so much. Yeah, so Dr. Weinstock and I will trade back and forth. And if you have questions, please feel free to put them in the question box. And we would love to have a discussion at the end. All right. So suicide is the top 10 cause of death for people under age 65 in the US. And there are effective interventions to prevent suicide. We know some things that help prevent suicide. But the biggest problem in suicide prevention is this. It's how do we get these effective suicide prevention interventions to people who need them, and especially those who aren't well connected with healthcare. We do know some suicide risk factors. So this is a picture taken from the American Foundation for Suicide Prevention website. These are known risk factors for suicide and suicide attempts, include, mental health conditions, substance use, environment or life factors like stressful events, death, divorce, job loss, a big change, prolonged stress, access to lethal means like firearms or drugs, and exposure to other suicides. And then historical factors like previous suicide attempts or a family history of suicide attempts. And, there are some myths about suicide. Decades ago, we used to talk about suicidal tendencies. We don't talk about that anymore because it's really understood much more as a reaction to things in the moment of the person becoming overwhelmed in the moment. And so, there's some research that shows that I believe that it's, 70% of people who attempted suicide thought about that or, started thinking about it or deciding to do something about it within an hour of when they did it, and half within 5 minutes. So things like lethal means restriction, keeping firearms locked and safe, especially if there's children in the home, or just keeping people away from lethal means and things that they can use to kill themselves does help prevent suicide. We have also run into this myth with folks in the criminal legal system that we were really quite surprised by. And the myth is that there are people who, some people who believe that, or suggest that if someone's suicidal when they're arrested, it means that they're guilty. And there's no evidence of that at all. And as a matter of fact, when Dr. Weinstock and I were doing a trial of people in jail who were at high risk for suicide, something like 97% of the attempts had happened before their arrest, not after. So often both the suicide attempt and the arrest are both symptoms of something else spinning wildly out of control in their lives. So let me tell you a story So this answers partially who's at risk, but it doesn't really answer when they're at risk. So let me tell you a story of someone we worked with. This man had been trying to rebuild his life, and one day something went wrong and he lost his job and his hope for the future. He started to get more anxious, and then he started drinking. As he became more intoxicated, he started having suicidal thoughts. They got worse throughout the evening, and he decided to end his life by crashing his car on the highway and making it appear an accident. But as he drove, he got pulled over by law enforcement. The police didn't realize they were encountering someone in an active suicide attempt. Instead of being taken to the hospital, he was arrested and detained in jail. So the criminal legal or criminal justice system in the US is vast and wide and complicated. Everything shown on here can be conceptualized to be part of the system. And, on any given day, most people who are criminal legal involved, even those who've been previously arrested, are actually in the community, not in custody, the vast majority. And jail is different from prison. So people in jail often only a few days. They may not be convicted. They may not even be charged. Jail is where you go when, you're arrested, the police take you somewhere, and then sometimes people are bailed out in a few days. Sometimes, different things happen. And in prison, people have been sentenced. But, these criminal legal contacts can include police contacts, arrest and jail detention. In terms of this crisis care continuum, we conceptualize 911 and crisis lines as part of this potential crisis care continuum. And these points of intervention are where, interventions can occur to change a mental health, a substance use, or potentially a criminal legal trajectory. So part of what our research has found is that the fact of a criminal legal contact, like contact with the police or spending a night in jail, actually marks suicide risk in the community. It's well known that there's a risk, especially right after arrest in jail, but the risk is actually higher when they get out. And our point here isn't about suicide in jail, although that is important. Our point here is about people in the community who've had contact with the criminal legal system being at greatly elevated risk for suicide. Because like I said, if you're ever going to be arrested, it's usually following a moment when things in your life are spinning out of control. And those interacting with criminal legal systems are especially likely to not be well connected to healthcare. So take a minute and to yourself, guess what percent of adults who die by suicide in the US spent at least one night in jail in the past year. So percent of US adult suicides, how many spent at least one night in jail in the past year? So our research has shown that 20% or 1 in 5 of adults who die by suicide in the community, so not in jail, in the community each year, has spent at least one night in jail in the past year. Therefore, this research has found an answer to one of the biggest problems in suicide prevention, which is how do you find people at risk when they are at risk? Our research has also identified the first evidence-based suicide prevention intervention for the 10 million releases from jail each year. And so that answers one big problem and a big problem for suicide prevention. And unfortunately, there's the second big problem, as there usually is, and I will talk more about that in a minute. I also wanted to highlight one finding on here. We did an analysis of all 3,000 and some counties and found that it was the accessibility of community mental health and substance use services, but not violent crime rate that predicted per capita county jail population. So having these services in the community really, really does help, and having them accessible and having this crisis continuum of care really does help keep people out of local jails. So like I said, we solved one big problem somewhat, but there's a second big problem. And this big problem has plagued work with individuals interacting with jails for decades. And those of you who are from these systems, this is going to be very familiar to you. So the 3,000 plus jails in the US are local. They're typically run by counties, but sometimes by cities. They're typically independent of each other, and they're just never, for the most part, going to have the capacity to link people back to community services that they need. We've been trying to do this for 40 or 50 years, but when you have in the US, 10 million admissions and discharges every year, people are in jail for only a few days. When they're admitted, they may be intoxicated, they may be acutely mentally ill. Releases are typically unscheduled, so maybe you're until tomorrow, maybe you're until 5 days from now, maybe you're until 28 days from now. We don't really know. And 2/3 of the folks going through jail have mental health problems, 75% have addiction problems, and the jails just aren't staffed to do it. The providers I know are doing everything they can, but they're just not, they can keep people alive, they can support them to the extent that they can while they're there. There are programs that try to connect people back to services in the community, but to do this at scale, it's really hard. And from the healthcare side, the healthcare providers like community mental health, for example, may not know their person was in jail, and they may drop them from care for missing appointments that they missed while they were in the jail, but the community mental health system doesn't know. So you might think that it could be possible to link all these systems electronically, but there are a few problems with that. One, privacy laws. Two, all the data is in different formats. If you manage to link in a city, jail and community mental health, you've solved that one time, and there's 3,000 jails and more than 2,500 community mental health centers and more than 14,000 addiction treatment centers. And the jails don't always have really strong IT capacity. So, this is the context. In this context, we were having a conversation with CareSource Managed Care Organization in Ohio. And they had come up with something very clever. And as you may know, in many states, not always, but in most states, arrest and release data are public, or at least not protected by privacy laws. Like the fact that someone was arrested or released is public and health data is private. And it turns out that technology has advanced to the point that it's possible to scan all this publicly available jail release data for matches to patients in a health system. So CareSource had realized that and was matching release data from the 108 Ohio jails against their own subscriber list each week. And making the connection this way is amazing because it doesn't require the release data to be in any particular format. It doesn't require direct coordination with the jails, right? Which is hard, and the jails have other things they're doing. It protects the privacy of the health data because it lives on the health side. And what this means is that we have a scalable way to let local health systems know that one of their patients was just released, so they can reach out and check on the person who may be in crisis. Because like I said, arrest can happen as a result of many things, but something that's pretty common is that arrest is following some kind of life crisis or instability or something that is, like I said, spinning out of control in someone's life. So we put all these ideas and this past work together. The idea that contact with the criminal legal system marks a high-risk time for suicide in the community, that we've discovered effective suicide prevention approaches for these groups, and we now have a way to let the health systems know to reach out, and this solves these two huge decades-long problems simultaneously. So we were awarded a $15.5 million center grant by the National Institute of Mental Health. It's co-led by me at MSU, Brian Amadani at Henry Ford Health, and Lauren Weinstock at Brown, to create the National Center for Health and Justice Integration for Suicide Prevention, or NCHATS. And it's a set of 8 related research projects that demonstrate and test suicide prevention approaches based on these ideas. And we're really excited about this because we worked really hard to make it pragmatic and scalable. We've worked with providers in community mental health and jails and police for a long time, and we know that there are real systemic barriers. And so we're not trying to create a fictional solution that can't be enacted. We're trying to create a real world solution. So among these studies are the 2 largest randomized suicide prevention trials ever. One is 60,000 people, one is 43,000 people. And the center is not only conducting important clinical research that we hope will save lives, but it's providing training in suicide prevention and criminal legal system for both, students and faculty on the academic side, but also clinicians in the community to try to help bring these worlds together. Like I said, suicide training in suicide prevention best practices for health and criminal legal systems. We have projects across the country, which we will talk more about in a minute, but I just want to highlight here that, you know, they're taking place across the country, Michigan, Massachusetts, Minnesota, Ohio, with lots of different systems. We're working with police in one project and emergency departments. We're working with CareSource, you know, Medicaid and community mental health and substance use providers. We're working with a health system in Project One, you know, trying to get this whole continuum of seeing, okay, so now that we can do this, now that we know that the contact with the jail indicates potential suicide risk, you know, what can we do to flag things on the health system side to let people know to reach out? So it's a huge effort. And the center involves more than 15 university and health systems that we're working with nationally. But more than that, I'm especially excited about our national group of partners. We have organizations of people with lived experience of suicide, lived experience of criminal legal contact, prosecutors, sheriffs, the American Foundation for Suicide Prevention, a really fantastic group of partners that the center brings together to work across silos to prevent suicide. You know, part of the goal here is to get members of different constituencies who may not always interact, you know, into a network, interacting, talking with each other to solve these cross-system problems. Again, we involve our partners in everything from beginning to end. You know, when system fragmentation is the problem, bringing key players together is a crucial step. And our goal is to create this community of partners that can engage in collaborative problem solving. This space is a slide basically saying that we're working on enacting solutions that work in the real world and that are scalable. And, you know, in a conclusion to this introduction to the center, I just want to say, you know, we have evidence-based suicide prevention interventions in the community. And what the center does is demonstrate and test new ways to identify some of the folks most at risk and connect them to those effective interventions to prevent suicide. So with that, I will turn the time to Dr. Weinstock to talk about the first of 4 projects, and she and I will just go back and forth and briefly describe these 4 projects and some of the clinical innovations that are being tested.
All right, I'll just be sharing my screen. Hopefully that is visible to everybody. Great. So as Dr. Johnson mentioned, as Jennifer mentioned, we have 4 component projects that make up a lot of the activities that we, not in total, but a lot of the activities that we are spending in our center. And the first of these projects is what's referred to as the signature project. And interestingly, it's supposed to be because it's supposed to be the largest project, but one of the benefits of the data infrastructure that we are trying to leverage in the center is that all of our projects are actually quite large because we're making use of available data and creating data linkages, as Jennifer mentioned, between the criminal, legal, and health systems. So that's a real thread that carries through all of the work that we're trying to do in scaling up evidence-based practices for suicide prevention for this population. So with that said, we have our signature project, which we refer to as the 5S trial, syncing screening and services for suicide prevention across the health. And actually, we've changed that to criminal legal system in our title, which I realized didn't change. To give you an overview of what this project aims to do. So as I mentioned, and as we kind of already emphasized as being a critical part of the work of our center, is that we're working to harmonize publicly available jail release data with health systems records within 2 large health systems that are involved in a larger project called the Mental Health Research Network. So this includes Henry Ford Health System in Detroit and Health Partners in Minnesota. And what we're able to do is crosswalk the data on recent jail release with the data that exists within the health system to identify individuals who are patients within those systems who have recently been released from jail. And what we're hoping to do is randomize them in this trial. The large majority of the people won't get the active intervention that we're evaluating, but something like 1,500 people will be randomized into our active intervention arm. And what that will include is immediate outreach from a care coordinator in these two health systems, outreaching, offering support and services, linking to care, as appropriate, doing risk assessment and safety planning if people reach a certain threshold of suicide risk, offering a caring contact. And then for those people who appear to be at highest risk, offering to do ongoing outreach through telephone support and using our Coping Long-Term with Active Suicide program, which is a telehealth delivered suicide prevention outreach intervention for individuals that has been previously evaluated in after ED discharge and discharge from inpatient units. And like all of our projects, we're particularly interested in whether this intervention will improve suicide outcomes over time. So this just gives you a sense of what this looks like. Again, we're kind of harmonizing these jail release data with the health systems data to identify individuals who could benefit from outreach. One thing that's really important, I think this is true in all of our interventions or all of our projects that involve outreach, is that we're not necessarily outreaching to people and saying, hey, we heard you just got out of jail. That's not really the focus, but rather just to say, hey, we're here for you. You're a patient in our system. We haven't seen you in a while. Is there anything we can do to help you? So we know from the health system side that this person might be at especially high risk because they've had a recent criminal legal incident, but it's not necessarily the approach we're taking directly with the patients clinically when we outreach to them, but rather it's just meant to be a caring outreach to somebody who's somehow engaged in the system. And it doesn't even need to be in a very intensive way. It could be somebody who's been seen once in the last year or two in the system. And then, the people who are randomized to our intervention arm will be given this, we call it a clinical care pathway of suicide prevention best practices. And then we evaluate over time what their suicide related outcomes are. So I think I'll end there and pop it over to the second project with Jennifer.
All right, fantastic. So while I'm pulling that up, while Lauren was talking, I had another thought, which is, it's not the majority of arrests, but it's something that I never really thought about before I started doing this work, is that, as in our example, some people end up in jail as a result of a suicide attempt. A lot of things folks do to attempt suicide are illegal. You think about drug overdose potentially, or picking a fight, or reckless driving, right? And so it's a small percent of cases, but there are cases where people end up, like I said, interacting with the police, the jail, exactly because they were making a suicide attempt. So this second project, we're working with CareSource, like I said, the managed care organization in Ohio that that had this idea to link the data to start with. And like I said, what's great about it is it doesn't require, it can be done by the health system. It doesn't require tunnels between the jail and the health system or anything else. The health system can just do it. So what this study does, so CareSource was really looking for a way to provide better services to their clients. They're a regional managed care organization. They do have many states. Again, we're working with the Ohio group, and they have Medicaid and non-Medicaid plans. But what we're working with is CareSource Medicaid Ohio. And they were thinking, okay, well, we're the managed care organization. What can we do to try to connect people to services? They were thinking across, mental health broadly, substance use, physical health. And we said, okay, well, we know how to do suicide prevention. So there is an evidence-based suicide prevention intervention called Caring Contacts. And the way this usually works is if someone's seen in an emergency department, or if someone is seen somewhere, especially for a suicide attempt, right? The caring contact, comes afterwards. So in the second example, dear Mr. Jones, it was an honor to serve you in the emergency department. We're here for you. Should you need anything, please contact us. And this is a really low dose intervention. Sometimes they send a couple of these over a period of time, but it's like sunscreen, right? Any one person wearing sunscreen doesn't necessarily prevent cancer, but when 1 million people wear sunscreen, it reduces a lot of incidence of cancer. So, and like I said, caring contacts have been found to prevent suicide attempts. So the way they're being used in this study is a little bit different, because, they weren't necessarily seen for a suicide attempt, and the letters are coming from CareSource, the managed care organization. But, the letters basically say things like this, we're just checking in with you. We wanted to let you know, that we think we're here for you. If you need something, you can call us here. And they are caring, non-demanding, just sort of, we're here if you need something, here's how to reach us. And CareSource found that of their 800,000 Ohio Medicaid subscribers, 43,000 or 5% went through at least one Ohio jail every year. So what we're doing is taking half of them, and CareSource is sending out these caring contacts. We did talked with people with lived experience, and they actually wanted physical letters instead of texts or emails. So they're sending physical letters that, like I said, have this brief caring message. It was interesting to try to get the messages out of HR speak or marketing speak. It's not like dear valued customer, it's dear so-and-so. It's a little more personal and a little more caring, and simply says, what the resources are, and they're there to help. So that's 43,000 people will either be randomized to get this or not get this in the year after, or in 1 year. So the study's big and it's happening kind of fast. Like I said, we're trying to do scalable. The second thing that they wanted to do is CareSource really wanted to support their practice agencies. So they're the payer, right? They're the one paying the claims, but they work with, agencies and clinics and provider groups. So in these large community behavioral health agencies, mental health and or substance use, we thought it was appropriate for either. What they're doing is sending reports to the agency when somebody in the agency, who the agency has seen recently, goes through the jail. So for example, I'm just going to make up the name of the jail. Say that my jail is, community mental health. I have Springdale Community Mental Health, right? If somebody that I've seen in the past 6 months, CareSource gets notification that they were released from jail or went into jail, then they would let the provider agency know, and then the provider agency can do outreach, right? And again, this doesn't sound like, hey, we know you were in jail, come in for an appointment, but this looks like, hi, hadn't seen you in a while, wanted to check in and see how you're doing, have the person talk, if they're struggling, they could do a quick screener over the phone, ask the person, again, not pressure them, but simply ask them, like, would you like to come back into services, or is there a referral we can give you? Any way we can help you? And they did that. And then Lauren and Greg Brown trained in these 12 agencies, the providers, or the folks who were outreaching, and they weren't always mental health providers. Like, they might be case managers, substance use counselors, in evidence-based, like suicide screening and, brief interventions to prevent suicide. And, a variety of folks can do these. You don't have to be a mental health clinician, but we gave the agency sort of best practice tools, and then how they choose to use them is up to them. But what we're asking them to do is, just kind of reach out, if you get notifications, see how the person's doing, if they need anything. And then a lot of times people get scared when talking about suicide, so we train them in best practice suicide assessment and prevention practices. So back to you, Lauren, for the third project.
Okay. Our slides going here. And slideshow. So for this project, I'm here basically speaking on behalf of our partners in Detroit at Wayne State and Henry Ford, and I saw there was a question in the chat specifically about suicide prevention in jail. And this is the one project in our study, in our center rather, that is uniquely focused on suicide prevention in jail and involves risk identification for people who are presenting in jails. And so this just reflects the Center for Behavioral Health and Justice, which is a center of excellence in Michigan at Wayne State. And there are many efforts which guide the work that they're doing in our center, but also more broadly in their communities. And again, this project is really touching upon the initial detention and initial court hearing intercept of the sequential intercept model that Jennifer presented earlier. And the rationale for this project, and again, probably is reflected in some of the background for the question that came through the chat, which is there are standards to guide identification and suicide risk in jails, but it is very challenging to do. As many of you know, booking areas are not private. Individuals may not be super forthcoming in the setting for a variety of reasons. And also there's a staffing issue in terms of having clinically trained individuals doing the screening versus other people who may not have that background or skill set. But we also know that improved suicide risk identification could decrease the adverse impacts that suicide has on detainees, their family, correctional staff, and the community. So if there are ways to enhance jail identification, that seems like it could potentially move the needle forward in terms of improving our systems for suicide prevention in jail. And so what this project aims to do is, again, as a tip of the hat to the Mental Health Research Network, they have been for at least 10 years now developing algorithms that kind of have multiple inputs that can be used to identify individuals who are at statistical risk for suicide. So this isn't the same as doing a clinical assessment and a clinician formulating or anyone formulating a judgment of clinical risk, but rather these are statistical models of risk that take a lot of very robust health and in some cases social determinants of health information from records to identify these tranches of risk for different individuals. So the idea was really exciting because the Michigan Department of Health and Human Services has recently integrated Medicaid claims data into the county jails. And so now the team in Michigan has the ability to access the Medicaid claims data, which will provide the inputs to run this risk algorithm to identify who might be at especially high risk for suicide. So again, it involves this access to big data to help inform suicide prevention practices that could be done in a scalable manner. So in this study, the aim is to pull Medicaid claims data from 6,000 individuals over the past, I think, 5 years who are booked into 3 jails that are participating in this work. And the idea is, one, to test whether the algorithm is effective in this population. So they're kind of modeling the algorithm based on what the Mental Health Research Network had done, but that was done in health systems, not in jails. So one step is just to understand how the algorithm operates in the population. And then the second aim is to compare that prediction model flag or risk flag, as many people think of it, to the current standard practice of clinical risk identification in jail to see if that increases the number of people who are identified at risk for suicide. So in other words, does using the risk algorithm help improve detection of suicide risk in jail? And then finally, to also evaluate whether, if that is true, if we enhance detection, whether that then has downstream impacts on suicide prevention, because presumably enhanced detection would kind of set somebody on a path to receive certain services or monitoring or outreach. So this is just a depiction of the model for this project. It's, in some ways it's pretty straightforward. It involves really complex analytics, but really the question is a simple one, which is, does this risk flag improve detection and downstream improve outcomes for people in jail? So very excited about that project. They, I think, are already working on the first aim of this project and preparing to launch the second aim, which is the actual application within jails. So stay tuned to hear how that goes. And I'll pass it back to Jennifer.
All right, let me pull up my slides. Okay. So the last project, and let me say a couple of things before I talk about this project so I don't forget them. This center is a 5-year center. We have the opportunity, I believe, to potentially be renewed for another 5 years. So we're in the beginning of this work still, and we're still looking for partners, inputs, anything else, if this is work or, you have thoughts that are relevant or you're potentially interested in being part of our, consortium, we'd love to hear from you. The email was on the previous slide. It's contact.nchats@msu.edu. And I can put it in anyway, we can put it in the chat, but we would, we'd love to partner with anyone who wants to partner. We're about to launch another 4 smaller projects. We have training opportunities. We have just a lot of ways for people to be involved. Yeah. And then to add one other thing to what Lauren said, the other piece of project too, these algorithms she's talking about, that's I don't know, kind of a impersonal sounding word, but what it does, we actually use them in project 2 also for the reports that go back to the providers. And simply, it's just a flag that said, hey, your person is in the top 5% or top 10% of risk of your population. So we nudge them, and they try to re-engage everyone who's coming out of the jail, but we give them an additional flag if, based on the claims data from the past few years that CareSource holds, it indicates like this person is statistically, in your top 5 to 10%. So especially, maybe prioritize that person. Okay. So the 4th project is led by Dr. Ben Cook and Dr. James Barrett. Ben is at the Cambridge Health Alliance, and Dr. Barrett's at the Cambridge Police Department. And I love this team, right, that we're trying to partner across silos as much as possible. So they are working with police and emergency departments. So a lot of times, in the systems where I've worked, when something goes wrong and, police need to get someone out of the situation, they have a couple choices of where to take them. One is the jail, one is the emergency department. Sometimes neither of those are super good option. So that's where we get all these, community crisis services. Does someone just need to go somewhere and sleep it off for a couple nights? We get folks in the jails with developmental disabilities or dementia, someone who is driving the wrong way down the street because of dementia, right? Which jail maybe isn't exactly the right place for them, or the jail nurses are struggling with what to do with this person, but the police didn't have another idea. So at the Cambridge Police Department, they've created this thing called the Family and Social Justice section. It involves all of these parts, right? Family justice group with domestic violence youth services, social justice group, and then it has like a clinical support unit. And Cambridge Police Department actually employs psychologists. Jamie Barrett's one of them. Again, to try to help with some of these cases. I was talking to a police department. They said they thought that about 40% of their calls were either mental health, substance use, or partner violence, domestic violence, right? So to kind of reduce the load from people who are calling a lot because of these other issues, and and get them connected to services so that, you know, and then the police can focus on other things. So here, this is their clinical support unit. They have a lot of services. I mean, I'll just let you look at them, right? They, you know, community services, they have, you know, criminal complaints involving mental health, you know, Section 35 substance abuse, focused deterrence. You know, they have a suite of services, but what they're looking at here, they already have in place a program where they have this, they call it the family and social justice section, where they've been piloting this in local emergency departments, where they have a social worker, I believe, who works. I get a little bit, like, some of these folks work in the emergency department, some work in the police department, and I can't remember where the social worker is placed, but they're assigned as a follow-up case for all of the police mental health calls for services. You know, they just follow, how is it going? Would you like, you know, support with this or that, case management to help address social determinants or whatever else is going on. The psychologist on their team supervises the cases assigned to the social worker, helps with them. They actually have a mental health resource police officer, which is a really interesting model where, you know, the person was detained by the police, they were taken to the hospital, they may or may not have been admitted, but then the police officer calls or comes, you know, and visits with them and said, hey, how's it going? You know, were you able to get your needs met? Are you connected with care? And there's something about it's not a mandate, right? They're not coming to say, hey, you must, but something about having that police presence, talking about, you know, you really should follow up with your treatment appointment, really does motivate treatment. And then the emergency department staff receive and triage patients, create a treatment follow-up and discharge plan, etc. So they're testing both the effectiveness of all those components I just said. So they're comparing just emergency department and police as usual to this suite of services, to adding a navigator who really can help coordinate between the police and the emergency department, you know, their efforts. And so, like I said, the goal here is for mental health related police contacts, you know, where there's emergency department, they may or may not be committed and it may or may not be voluntary, either way, but where the police and the emergency department can work together to try to help the person have the care that they need, so they're not, you know, the police aren't picking them up the next week for the exact same problem. So I will stop there for now. Lauren, do you have, before we take questions, do you have any follow-up thoughts?
No, other than just to add that one of the really nice benefits of having the center funding is that in addition to the 4 projects that were proposed when we first proposed the center to NIMH, we also have funding to fund pilot projects as well. And although those have not been officially awarded at this time for mostly administrative reasons, I just wanted to add that one exciting thing about those pilot projects is that it will also allow us to extend some of the work that we're doing into the juvenile legal setting as well, which I think we all agree is an area that deserves a lot of attention. And we look forward to sharing those at a future time when we're able to talk more about them.
Yeah, and we have projects looking at courts, right, at different intercepts all along this model. So really trying to do what we can in all the places where it makes sense.
Yeah.